Good morning, everyone. I am Dr. Kunal Sehgl from Mumbai at Sehgl Path Lab. At the outset, I would like to apologize for not being able to be present there in Delhi physically as I had to travel out of India. But I would like to thank the whole ISMPO team and especially Dr. Prashant for giving me this opportunity to be part of this very unique program. The topic given to me today was to discuss with you about the role of flow cytometry in lymphoma diagnosis. And to start with, uh, Uh, we need to remember that lymphoma diagnosis is a multidisciplinary approach. And if you see, starting from the history to the basic workup like a CBC, ESR, to radiological evaluation, molecular studies, histopath, including lymph node evaluations or biopsy evaluations, flow cytometry immunophenotyping forms a very small but very important role in the diagnosis of lymphomas. So we go to the role of lymphomas. Typically, the role of lymphoma or flow in lymphoma would be to diagnose a lymphoma versus diagnosis of a reactive lymphoid population. We need flow for typing and subclassification. For example, B cell CLPDs, T cell CLPDs, NK CLPDs, and within the B CLPDs is CLL, a mantle or follicular, and so on, as we'll see. And within CLL, for example, we have prognostic markers like 38 and 49D. And we'll discuss that as we go ahead. For want of time today, because it's a short talk, I have kept the focus on a case-based approach to a B cell lymphoma classification. And if one were to go back, say 10, 15 years ago, the classical B cell CL lymphoma classification remains mainly focused on whether the tumor is CD5 positive or CD5 negative. Within the five positive groups, as we know, we have CLL, which are typically dim 20, dim light chain expression, with being negative for FMC7. Whereas mantles are other five positive lymphomas, which typically have a bright 20 and a bright light chain expression with an FMC7 positivity. If 5 is negative and then the 10 is positive, typically we have the follicular center cell original lymphomas, which is the follicular lymphoma, or DLBCL or a Burkitt's. If 10 is negative and 5 is negative, this becomes the 5 negative, 10 negative basket, which contains hairy cell leukemias, hairy cell leukemia variant, marginal zone lymphomas, and lymphoplasmatic lymphomas. So typically for CLL diagnosis, we had the old Matute score, which many of us would have used, and had involvement of these antibodies, which is surface IgM 523, 79, BNFM7. And over the period of years, you have advent of newer markers. And in this 2017 BGR article, it emphasizes the role of CD200, which we're going to see as part of the new CLL score, which had marked increased specificity for diagnosis of CLL. Similar to 200, there have been other markers like CD148, CD180, which have come along to help us in the diagnosis of lymphoma. So, for example, CLL typically have CD200 expression, which is negative in mantle cell lymphomas, whereas mantle cell lymphomas have a strong 148 expression, and spinning marginal zone lymphomas typically may have a variable 200, but show expression of CD180. Even the Euroflow group, which has been one of the most leading groups in terms of standardizing lymphomas and leukemias and their panels, have also shown the importance of CD200. So basically, what I wanted to show is as things have moved, the newer markers have come across, and we also have to move from the typical 523 expression in CLL and start moving to newer markers. Now, for the sake of discussion, this is our old 8-color antibody panel. We are currently using 10 to 12 color antibody panels for our leukemia lymphoma diagnosis. But for the sake of our case presentation and learning today, it is simple. The first is a B cell tube which contains kappa lambda. It shows CD38. It has 19 for B cell gating along with CD20. It also has CD5 and 10 as is showed in the typical classification. Again, then you have additional markers like CD243. We'll assess 49D and 38 as prognostic markers. You have a T cell tube, you have hairy cell markers, you have additional T cell markers if required in T cell lymphoma, which we won't be discussing today. So if I move to my first case, the 55-year-old gentleman with routine health checkup, close to normal hemoglobin at 12, normal platelets at 2.5 lakhs, had a incidental high count of 26,000 with absolute lymphocytosis being 87% of lymphocytes. See the morphology, all small to medium sized uniform looking lymphocytes, the few smudge cells. And typically what is defined in CLL is a football or a soccer ball chromatin. If you see these light and dark areas alternating amongst the two. What I'm going to show you in the flow is the role of CD45 gating. So this is for any peripheral blood. The bright 45 cells on the x-axis are colored in blue, which is the lymphocyte. I have used uniform color scheme throughout my presentation. So your bright 19 positive, which are 5 negative, are your normal B cells, which will be marked in pink. The clonal B cells, which in this case are 19 and 5 positive, are going to be marked in red. Your normal T cells, which are 5 positive but 19 negative, are marked in green. The leftover cells amongst the lymphocytes gated out of this 45 area, which are neither B nor T, are your NK cells. So pink is the normal B cells, red is the cell of interest because today is a discussion on B cell lymphomas, and green is the background normal T cells. So in this particular case of incidental lymphocytosis, if you see in the kappa lambda, the pink cells are polyclonal. However, the clonal cells which are 19.5 expressing show dim kappa. Compared to the normal B cells showing a bright 20 expression, the red colored clonal cells have a moderate heterogeneous weak 20 expression. The clonal cells are negative for 38 and negative for CD10. They are negative for 49D. They show moderate 23 expression and a very uniform 243 expression. Compared to the normal B cells show a moderate heterogeneous 200 expression with absence of 43, whereas the CLL cells in this scenario or the clonal cells express homogeneous 200 with a 43. Now, this is a very classical presentation of a CLL. One homogeneous 243 expression, a heterogeneous 20 expression, and a dim kappa expression in this 5 positive CLPD. And a very classical presentation of incidental lymphocytosis at a low count. So within CLL, I'm showing you in the top row one case, which is 38 negative, the case which I just showed you in 49D negative. Whereas in this second case, you will see 38 homogeneous expression, also a sort of a moderate 49D expression. Why am I showing you this? Because presence of 38 and or 49D together are known to be poor prognostic markers in a case of CLL. And C38 has correlation, positivity has correlation with the unmutated status in IGHV mutation analysis. So this is one example of how a patient within 7 months of time progressed from 30,000 to 87,000, and within the next month or so started progressing very rapidly. This was a 3849D positive patient which I showed you. And when we went on to do FISH, this patient had a ATM11Q translocation, which is a high risk translocation in such a scenario. So moving to the next case, if I show you another case of lymphocytosis in the peripheral blood, what here I wanted to focus on is compared to normal lymphocyte, this is difficult. If you ask me, is it normal or abnormal lymphocyte, I can't make out. But there are certain clues in lymphocytes like this, which have a notch here, again, some irregular nuclear contours. When you start seeing these notches, and if you carefully see this line, there's a cleaving here. It's like a folding of a nuclei, again, a notch or a cleft. This notch or cleft is something unusual. And two lymphomas where we see these notches and clefts very often are mantle cell lymphomas and follicular lymphoma. These are just subtle clues. You need to confirm that on flow. Now, for reference, I have kept a CLL case which you just saw previously here on the top. And below is another patient. Again, I am seeing the red clonal population being 19 and 5 positive. Here, the lambda is brightly positive. Compared to the CLL case, see, this is where the lambda intensity is bright. And here, the lambda intensity of the clonal population is as bright as normal shown in the previous case. In contrast, 200 is completely negative, 43 is negative, and the 19 is positive with 23 being negative. So here now we have a 5 positive tumor, which will not believe me also has a bright CD20 expression, has a bright lambda light chain, absence of 200, and absence of 23. This is typical of what we call as the mantle cell phenotype. As I said, the 20 was bright, and this is a mantle cell lymphoma compared to the CLL. So, three major differences: bright CD20, absence of 200, and a bright lambda light chain expression in a 5 positive tumor. Obviously, you need to confirm this by cyclin D1 as FISH for cyclin D1 on the FISH analysis on peripheral blood itself, or one can do cyclin D1 IHC and Soxylan IHC on the bone marrow biopsy. CD200, as I highlighted, becomes a very important marker, brightly present in CLL, virtually almost always absent in mantle cell. Other lymphomas which express 200 brightly are hairy cell leukemias, as we will see when we go along. If I can move to the next case, this is a 72-year-old who had persistent lymphocytosis with mild anemia. Where Google read and wanted to know is my lymphocytes abnormal or not. So physician sent him for flow. And if you see the red color cells here are the B cells, where 36% of all the lymphocytes get it. The remaining are the green T cells and NK cells around 4%. Of the red lymphocytes, what I want to show you in the 19 and 5 plot, if you see the blue color cells and the red, normally you have majority of the normal B cells are 5 negative. Small naive cell population of 5 dim positive cells may be seen, but here it's the reverse. Majority of the cells are a dim 5 expressing red population, and a very small population appears to be the 1945. So the blue cells, if you see on the kappa lambda plot over here, are polyclonal. But if you see the red population down here, majority of them are showing a lambda expression, a 5, and a heterogeneous 23 expression. This is a very small lymphoid population. Why I'm emphasizing on this small population? The phenotype, again, you will say, is it like a CLL phenotype with a heterogeneous 23 or heterogeneous 20, a 19.5 population? Yes, it does look, but the B cells were only 36% of all lymphoid cells, and their absolute count is 873. So even though I am seeing a CLL phenotype, in such patients, it is important to know whether there was what is the clonal WBC count and the clonal B cell population. By the definition of IWCLL, CLL can be diagnosed only when the clonal B cell population above 5,000. And as you see in this case, it was less than 1,000 to the 821, which means this falls into the category of monoclonal B cell lymphocytosis. Other category of MBL are met, like absence of lymph nodes, organomegaly, absence of previously diagnosed disease, and no history of treatment, and so on. So it is important to recognize MBL and this different from CLL. If I move to the next case, again, I'm highlighting some lymphocytes compared to a little smaller ones which we are seeing. This is slightly medium to large size. Again, if you see, say, some clefting, there is some folding over here, some edge irregularity. Again, this could be a subtle clue that we are dealing with a lymphoma. Patient had lymphocytosis. We did a flow. Now, compared to the normal B cells in pink again, the red population here is a little heterogeneous in 19, dim variable 19. It has 10 expression. It has a bright lambda. It is a bright 20 with variable 38 on the x-axis. Again, a co-homogeneous expression of 10 and 20. It is negative for 43. Over here, the green cells are the normal control for 43. And 200 is a variable heterogeneous expression. So all in all, a dim variable 19, but absence of 5 and presence of 10. Now, presence of 10, as we had seen in the original classification, favors a follicular center cell origin. These were small to medium in size. So this is consistent with the diagnosis of a follicular center cell lymphoma. Now, I'll show you another case, and I'll highlight why I'm showing you this case. This came as query acute leukemia. There were 80% blast on the smear, blast-like cells, and immediately an acute leukemia panel was ordered by the clinician, and a flow was done for an acute leukemia panel. Again, what I would like to highlight, majority of the cells were lying in this 45 area. Significant population was co-expressing 19 and 10, and I have colored them red in color. So 10 expressing, 19 expressing population. And here, if you see, all the red cells are lying in the bright 45 area. And they also express a very bright 20 being 34 negative. Remember, a 10, 19, 20 phenotype can also be seen in acute leukemias. Most acute leukemias commonly, or a BLL, will be 34 positive and 45 dim to negative. And now this is important to recognize. It got identified as query acute leukemia because they were large blast-like cells. But what if it is a lymphoma? Here, the clue is the 45 is bright, the 34 is negative, and you have bright 20. So even if we have put a leukemia panel, we put an additional tube going ahead and we assess clonality and clear cut all your tumor cells were expressing kappa. There's some normal lambda cells also in the background. And like most high-grade lymphomas which express c-MYC, they express moderate homogeneous amount of CD38. So now this was a 38 positive, 10 positive, bright 45, 20 positive kappa lymphoma. Now you will say 10 positive means follicular center cell lymphoma, which means, and you saw, based on the scatter, based on the size, these were large B cells, hence they were thought of blast. So on flow, we have two differences. This is either a high-grade DLBCL or a DLBCL simply, not the typical high-grade DLBCL of double A, triple A type. On flow, that's not what we are saying. We are saying a DLBCL versus a Burkitt's lymphoma. Now, that's a very critical diagnosis. But if I showed you the morphology which I had hidden for you, okay, one would say, okay, this is a very classic Burkitt's lymphoma. This patient was translocation 814 and c-MYC positive. And this is a classical Burkitt's lymphoma and flow. Take home message 10, 20, 38 as a combination. Large cells, think of DLBCL or Burkitt's. Small to medium sized cells, follicular center cell origin, and typically that's a follicular lymphoma. Again, size one can also see on the scatter. Forward scatter represents size compared to the blue normal lymphocyte size. The red cells were very large in size, which is what we saw. So moving to another case. Now this case, again lymphocytosis, a bright kappa expression. The B cells are negative for 20. These are 19 positive B cells. They are negative for 5. Bright kappa and a bright 20 without 23 expression. Here, they are also negative for 10, variable 38, and a good 22 expression with FFG7. So we are definitely dealing with a 5 negative lymphoma. It is also 10 negative. So we enter into the third major category, which is the 5 negative, 10 negative category. Now, whenever you get 5 negativity and 10 negativity, the first thing one should do is rule out all the hairy cell leukemia markers. And obviously, one needs to go back on morphology. And purposely, because this is a talk on flow, not going towards the morphology first, but showing you flow plot second. So when I show you the hairy cell markers in this scenario, which are nothing but 11C, 25, 103, and 123, they're all four markers present classically in all hairy cell leukemias. And they were uniformly positive in this case, fitting the diagnosis of a hairy cell leukemia. And if you went back to the morphology again, you have these classical hairy cells showing cytoplasmic projections. And another typical feature of hairy cells is the large cell size, and they're lying in the monocytoid region because of their morphology being a little monocytoid and a little irregular cytoplasmic projections, which cause the cell size to become larger compared to normal lymphocytes. Now let's look at one more case, similar type. Again, 19 positive. You see, again, compared to the green cells on the 45, the red cells have a slightly higher scatter, which means a little larger in size and a little scatter. Now, this case also expresses 10, has a bright kappa, bright 20, a very bright CD20 expression compared to normal, and has a very bright homogeneous 200 with absence of 43. Now, in the beginning, I had said a case other than CLL is expressed bright 200 is hairy cell leukemia. But I also showed you 10 positivity is a feature of follicular center cell. But beware, a small subset of hairy cell leukemias also express a dim variable 10. So one just cannot define a B cell lymphoma. Okay, 10 means follicular center. We need to do a complete set of markers, which was done in this case. And the 200 bright positivity was a big clue, again emphasizing the role of 200 in B cell CLPD classifications. And 123, 103, 25, 11C were all four positive. And we had a classical morphology to label this as a hairy cell leukemia. So the bright 200 expression is very useful. And in contrast, in hairy cell leukemia variants, that is completely absent. Now, this is another patient, 50-year-old, splenomegaly, peripheral lymphocytosis. Again, a little dim variable CD5, majority of the cells being 5 negative and 19 positive in red. A bright lambda, a bright 20, negative for 5, negative for 10. Okay, a little dim to negative CD200 expression. So first things, 5 negative, 10 negative B cell lymphoma, maybe if you count a subset of dim 5, that's fair enough, but not looking like a typical CLL or a mantle. We did the hairy cell markers. In this scenario, I have normal dendritic cells in purple, which are 123 positive, which is my internal normal control. And my tumor cells are 103 positive, 11C positive, but 25, 123 negative. Now, this is the erstwhile hairy cell leukemia variant. Now, this new entity, in the new WHO, this entity has been removed and clubbed together into splenic lymphomas with prominent nucleoli. But in absence of 123 and 25, in presence of 11C and 103, specifically 103, this is the erstwhile entity of hairy cell leukemia variant and typically is dim to negative 200. Contrast, hairy cells are almost always bright 200 and bright 123. Now, this is the last case I will show you for today in the B cell CLPDs. So this is leukocytosis with splenomegaly. These cells, if you see, are definitely a little medium to large size, and they had moderate to abundant amount of cytoplasm. Again, the red color population is the population of interest. 19 bright, 5 negative compared to the green T cells. A very bright lambda expression, a bright 20 expression, a 10 negativity. So again, we are discussing a 5 negative, 10 negative B cell lymphoma. 10 negativity over here, variable 38. 200, neither very bright homogeneous, neither negative, but like a variable 200. 23 is dim variable in this case. So you have a 5 negative, 10 negative. Again, I'll ask you to show me the hairy cell markers. Here, the hairy cell markers are negative in the form of 103, 123. 11C dim subset shows expression, but 25 is negative. the green T cells, red cells. And however, there is 180 expression in these cells. As I said, 180 expression in the initial part is seen in splenic margin zone lymphomas, and splenic margin zone lymphomas may show dim variable 11C expression, but typically hairy cell markers are negative. They have this classical phenotype of having splenomegaly with very monotonous looking monocytoid uh, lymphoid cells with moderate cytoplasm. So to re-emphasize, what I've shown you today is the approach to classification of BCLPDs by flow. This is just a short gist in a short period of time. But again, take home message would be this is a multidisciplinary approach and you need to correlate with all the other markers. Sometimes biopsies is required, sometimes a primary lymph node biopsy will be required. You need to confer to the radiological studies, you need to do FISH studies, say in a Burkitt's lymphoma, say in a double hit, triple hit lymphoma. So you need to combine your approach before you can give a final diagnosis of lymphoma. With that, I would like to thank my complete team